My name is Andrea Wallace, and I did my Geriatric Syndrome presentation on dizziness. Dizziness is described as a disturbance in a person's sense of relationship to space, exemplified by a sensation of unsteadiness and a feeling of movement occurring within the head. Dizziness is a common patient complaint within healthcare. According to the American Family Physician, dizziness accounts for 5% of primary care clinic visits. For this case study, the patient has an allergy to penicillin. Her current medications include metformin 500 milligrams twice daily, Trulicity 0.75 milligrams subcutaneous weekly injection, rosuvastatin 20 milligrams once daily, lisinopril 10 milligrams once daily, omeprazole 20 milligrams once daily, Bastolic 2.5 milligrams twice daily, and Zyrtec 10 milligrams as needed. She reports receiving childhood immunizations and has received the pneumococcal, influenza, and Tdap vaccines in 2018. Patient reports exercising 3 days per week. Exercise education was given to the patient and the importance that it has on the overall health status of the patient. The adverse health effects of inactivity among older adults have been well documented. The resultant weakness and instability associated with inactivity can lead to a higher risk of injurious falls, hip fractures, and frailty. Recently, evidence has documented that community-based exercise programs are associated with a lower risk of injurious falls. Her past medical history includes type 2 diabetes, dyslipidemia, gastroesophageal reflux disease, palpitations, and seasonal allergies. Her surgical history includes 3 uncomplicated vaginal deliveries and a meniscal repair at age 57. She denies any transfusions. Patients with dizziness may present with nausea, vomiting, unsteadiness, hearing loss, visual disturbances, tinnitus, pallor, palpitations, and syncope. The patient may be orthostatic or an arrhythmia may be present. Review systems for this patient: general, no fever, chills, weakness, fatigue, or recent weight gain or loss. She denies visual problems, hearing loss, headache, nasal drainage, or sore throat. She is currently having palpitations, shortness of breath, but denies chest pain or syncope. She denies cough or wheezing, no heartburn, nausea, changes in bowel habits, or abdominal pain, no urinary frequency, burning, urgency, or flank pain. She's currently sexually active with spouse and satisfied. She's postmenopausal and went through menopause at age 52. She denies joint pain, stiffness, or back pain. No headache, dizziness, numbness, changes in mood or memory. She denies depression and anxiety. She's not anemic. There are no large lymph nodes or bruising tendency. She denies rashes, abrasions, dryness, or changes in color. Blood pressure is 126/82, heart rate 102 beats per minute and irregular, respiration rate 18 and regular, temperature is 98.6, oxygen saturation 99% on room air. She's well groomed, that was ambulatory into the office without assistance, and she's alert and oriented and in no acute distress at this time. On physical exam, positive pertinent findings include heart rate of 102 and irregular. There was no bruit, auscultated, and capillary refill is brisk. Radial pulses are strong and palpable. Negative pertinent findings include tympanic membrane is pearly white in color and light reflex is present. Hearing is intact. Her respiratory rate is 18. Symmetrical chest wall movement, lungs clear to auscultation bilaterally, resonance upon percussion bilaterally, and no bronchophony present. Abdomen is symmetric, soft, non-tender, no masses or hepatomegaly present. Positive bowel sounds times 4 quadrants and inguinal lymph nodes are not palpable. She's alert and orient times 3. She has full range of motion and strength is 5 out of 5 in upper and lower bilateral extremities. Her skin is clean, dry, and intact. The screening tools used were the frailty assessment, in which she scored 1, hearing handicap inventory, a total score of 4, Geriatric Depression Scale, total score of 1, and the Oral Health, total score of 1. The patient did not show any signs of frailty, hearing impairment, or depression. The patient showed high functional ability with a low-risk falls injury. Diagnostics used were EKG and echocardiogram. The plan: as a healthcare provider, I plan to recognize polypharmacy and utilize evidence-based strategies to prevent negative clinical outcomes. Older adults, individuals using multiple medicines, and people using high-risk medicines are more likely to experience adverse drug reactions. The combination of physiological changes and multiple medication often increases the risk of adverse drug events. This patient is specifically at risk for falls, injury, bruising, bleeding, and dizziness. She will be educated that she does have atrial fibrillation, and she will be prescribed Eliquis 5 milligrams twice daily, and she will also increase her Bystolic to 5 milligrams twice daily. The Eliquis gives her stroke prevention, and Bystolic will give her rate control. A comprehensive treatment plan must address the 3 cornerstones of atrial fibrillation management: rate control, rhythm control, and prevention of thromboembolism. She will be cautioned that Eliquis can increase bruising and bleeding. Her medications can cause dizziness, making her more at risk for falls. She will also be scheduled to get an echocardiogram done to identify any structural, functional, and hemodynamic abnormalities in the cardiovascular system. Lastly, she will be referred to cardiology for evaluation. I educated her on the importance of monitoring her blood pressure to ensure it is not too low. Differential diagnoses for dizziness include lightheadedness, in which patients may describe this as a feeling woozy and is often associated with anxiety or depression. Disequilibrium, patients describe this as a sense of imbalance, and it may be a sensation localized to the body and relieved by bracing oneself, sitting, or lying down. Syncope, actual loss of consciousness. Symptoms may include perspiration, pallor, and palpitations. Final diagnosis is dizziness. The patient's having palpitations and shortness of breath. She's currently taking Bystolic and lisinopril. Cardiovascular causes of dizziness may include orthostatic hypotension, cardiac arrhythmia, myocardial infarction, and carotid artery stenosis. Especially in the elderly, sensory deficit, peripheral neuropathy, poor vision, and polypharmacy, which is greater than 5 medications, are common causes of dizziness. Community resources needed for this patient she will be referred to cardiology for her atrial fibrillation. The multidisciplinary team involved includes primary care provider, cardiologist, and pharmacist. In order to provide culturally competent care, the provider must understand the patient's view on healthcare, encouraging them to discuss their values and beliefs regarding healthcare practices. The provider should encourage involvement from the patient regarding their healthcare. I think that I successfully managed and treated this patient while in the primary care setting. Rate and rhythm control as well as thromboprophylaxis were addressed and treated. I used evidence-based practice guidelines to provide high-quality patient care. I utilized proper interview technique and assessment to provide competent geriatric patient care with multiple comorbidities and polypharmacy.